Okay, so this next case, there's no talk about evidence base, it's just an interesting case that sums up so many findings that you see on echo, on bedside echo, with someone with pulmonary hypertension. It's a 47-year-old with difficulty in breathing, a recent chest infection, not better with antibiotics. Upon arrival, blood pressure was about 80/60, with rest rate of 18 and sat about 90 room air. She's a non-pulmonary hypertension. So there are many things you see in this paroxysmal lung axis view. So firstly, the right ventricular outflow tract looks very, very dilated. The left ventricle is a bit thickened and doesn't look very happy, does it? And obviously you see a decent amount of pericardial effusion, and you see the descending aorta doing okay there. Move on to the next view. This is meant to be the left ventricle. The right ventricle is quite dilated. Again, posteriorly, you've got a decent amount of pericardial effusion. In this corner, what you see is your pleural effusion. What is interesting is what we call it a D-shape movement of the septum in systole, which is a good marker for pressure overload of a right ventricle, as you see this kind of D-shape change. Moving to the apical four-chamber view, what you see is actually the left ventricle end-diastolic diameter is actually smaller than the right ventricle. That's another good marker that shows RV dilation. Obviously happens in pulmonary hypertension, and again you see the decent amount of pericardial effusion. Moving over to the subcostal view, the one important thing that you see in subcostal view is the thickness of the RV wall. And clearly it's more than 0.5 centimeter. Again, you see the right ventricle trabeculation, and you see a small amount of effusion there. So this patient had more effusion posteriorly, which made it, obviously makes it harder to tap. And moving on to IVC. As you can see, the IVC diameter is big, it's above 21 millimeter, and it's not collapsing as much. That's just a random valve in the venous system. To put the probe on her lung, and you see this is a good definition of, if I hold it here, air bronchogram. This is the consolidated lung, and you see the pleural effusion, which is actually a decent amount of pleural effusion, as you can see it. Whether this fluid is paramnemonic or related to the fact that she's in heart failure, well, got enough reason to have that. Treatment options for her. So we gave her IV antibiotics for possible infection. Markers of infection were raised. Although there was a decent amount of pericardial effusion, but there was no evidence of actual tamponade. So we tried 250 of fluid boluses, which actually helped. Later on, there was an evidence of AKRS stage 2 on the blood test, which meant that we actually needed to be quite careful in terms of what diuretic to give and amount of fluid that we're going to give her. She ended up having a CT chest abdo pelvis, which showed a tumor a nodule in the lung and with a possible mass in the belly, unfortunately. It was a very good case from my point of view to show not all, some features that you see in PUL to assess the RV on bedside echo. So the things that we quickly looked at and mentioned was just the RV wall thickness of more than 5mm on your subcostal view is quite important. TAPSE below 17mm. TAPSE is your tricuspid annular plane systolic excursion that you just measure it. I'll have another video about that later on. Measuring the endostolic diameter of the RV and compare it to LV. If it's above 1, it's a marker of the RV dilation. And then the D-shaped LV in systole is a marker of pressure overload. And never forget, check your IVC. Is it collapsing? Obviously, it's not a direct marker of everything, but it is helpful in combination with other features that you see.